Hello, good afternoon. We are back on our studio from Vitro Life Group at ASRM, and with our last presentation of the day, that will be fantastic. We have Dr. Danny Sakkas. Danny Sakkas is the Chief Scientific Officer on Boston IVF, part of EVRMA Group, and Dr. Sakkas is going to talk to us today about non-invasive PGT-A, our Embrace technology. Danny?
Thank you, Juliana. So I'm going to talk about not the outcomes from Embrace, but I'm going to talk about the concerns you have about implementing a non-invasive PGT-A program. So the main concerns are obviously, the laboratory concerns in changing and changing your protocols and what you can expect. So next, please. I don't have a clicker. Do you have? Oh, thank you. Okay. So I'm going to talk about non-invasive PGT, as you've been hearing all along. And this is, it was a surprise in the end that, you could find DNA in the culture media, and even more of a surprise that the DNA in the culture media actually had possibly some importance in terms of telling you if an embryo was euploid or aneuploid or abnormal or not normal. So this was first published in 2016, and we were part of a very large multi-centre study looking at over 1,300 blastocysts that was performed by the iGenomics group, and that was an interim analysis, and hopefully the new paper looking at nearly 3,000 blastocysts is going to come out in the near future, I would hope. But what I'm going to talk about is some data that was sort of corollary, if you want, to the study from the multi-centre study we performed. So a number of studies have come out of this study, and one of the first questions we had is, is there really DNA in the culture media? And we were very lucky in walking around the streets. We ran into a guy called Nicholas Plachter, a brilliant imaging specialist, and we actually, with him, we actually tried to answer the question: do blastocysts or human embryos actually secrete DNA, or do they actually bud out DNA? And we were very lucky in they had developed a technique using these special fluorochromes called spy fluorochromes, where we could actually label blastocysts and we could do live imaging on them as they developed along. And this was the paper that we published. It had a number of other interesting observations, but one of the most amazing observations we had was that these embryos, if you watch this as a blastocyst, and you'll see actual nuclear DNA being budded off by cells. And this was amazing. And it's not every single cell, obviously, in the blastocyst, but what we identified were two things: that it was mostly trophectoderm cells, and it appeared that as mitosis involved and the change in the morphology of the blastocyst occurred, that the trophectoderm in some way would be squeezed and would bud off nuclear DNA. The other corollary to this we found was that actually, if you biopsied or you mimicked the biopsy technique, you would actually see more nuclear DNA being budded off. But what we did was answer the first question we had: is this really a true phenomenon? And we saw nuclear DNA being budded off in human blastocysts, and we also saw it in mouse blastocysts. So our first question was that, is this a mistake? Is it something happening by error? Was answered because we saw it off. The other thing we knew was that these were not apoptotic cells. It was something actually programmed in the blastocyst itself. So we could track these down, and this is done by Anna Domingo, who actually, with confocal microscopy, we could track individual cells, and we could actually watch as cells actually budded off this nuclear DNA. Now, if you ask me what the nuclear DNA is there for, what the budded off is, I could only give you a hypothesis. We're still trying to work out why is the embryo actually putting this off. But we know that the nuclear DNA is being extruded by the blastocyst. So it brings me to non-invasive PGT-A and why you would look at it or why you would not look at it, and the pros and cons of actually implementing possibly non-invasive PGT-A in your laboratory. So the pros are that it would save you time. You're not actually biopsying every single embryo. You're just working with the media. The other one is that you do not need a trained embryologist to perform the trophectoderm biopsy. It's quite a complicated technique, but all you need to do is actually wash the embryos through a few drops. Most of the embryologists know how to do that, and collect some media. So it's a pretty innocuous technique if you want. The other thing, and we have really very little proof about this, it removes the theoretical harm of the biopsy technique. So there are some positives to doing non-invasive PGT. What about the cons? So it's a new technique. Everyone hates adopting a new technique, and the labs, the last thing they want is me walking into the lab and saying, I've got a new technique for you. And my lab hates that, basically. But there are other things that we were unsure about. Are the concordance rates acceptable? Now, in the large multi-centre trial, we were up to about 80% concordance. And whether that's good, that's not bad, but it actually still means that 20% of the times, you're really not sure about that embryo that might be actually, what its chromosome constituency might be. The other concern is more of an embryological concern, is because of the way the protocol was evolved, you actually had to culture embryos from day 4 to day 6 or 7 in a new culture media drop. So you were not freezing embryos at day 5. So does the change in culture protocol cause harm to actually, you might be gaining information about the PGT status of an embryo, but are you actually causing harm because you're keeping them an extra day? So during the course of the multi-centre study, we actually gathered quite a bit of information about these two techniques and actually some other techniques that we looked at to actually try to improve the concordance rate. So I'm going to show you some of the data we had. So firstly, I'd just like to show you the protocol that if you were adopting non-invasive PGT. So the classic trophectoderm biopsy, what most of you are probably doing in your lab. So you would change dishes at day 3. You start doing individual culture on day 3, and then you continue this culture, and then day 5, day 6, and some labs day 7, you would biopsy, freeze, and proceed with invasive PGT. Now, to do non-invasive PGT, you obviously proceed the same way. On day 3, the way we were doing it, we'd set up new culture media drops, individual drops. We would wash our embryos, put them in the new drops, skip day 5, so our embryologists were very relaxed on day 5. And then day 6 and day 7, we would just take media, freeze the embryos, and then send out the media for analysis. So it's, in many ways, it's a more simplistic protocol, but people are still worried about two things. One, the washing procedure, and two, actually, that you were skipping day 5 and you're not freezing day 5 embryos. So these are normally your best embryos, theoretically. So are you actually causing some harm by actually not freezing your best embryos on day 5? So we first looked at what the impact of actually employing a non-invasive pre-implantation genetic protocol on viability and outcome. So as I said, we were doing the multi-centre study. We were actually culturing all our embryos to day 6 and skipping day 5 freezing. So what did we find? So firstly, we actually followed the protocol, and what we were able to do is compare all the patients that we had in the day 6 protocol, if you want, versus all our standard PGT protocols. So doing invasive PGT, freezing on day 5, day 6, and day 7. So you can see the patient groups were very similar. You can see that when some of the other groups, some of the other clinics in the multi-centre trial were doing the majority of embryos on day 6, but they were still doing some day 5 freezing. But what was important is two things. You can see here the number of biopsied embryos. This is our control, the ones we were doing with the standard protocol. We were doing day 5, day 6, and day 7. And you can see in the study we did over 350 blastocysts where we didn't freeze any or didn't do any biopsies on day 5, but everything was done, the majority, on day 6. So how informative were these? You can see that day 5 we actually had, out of 355 embryos, we did no clinical protocol on day 5. But you can see here the majority in the study were done day 6, but some were done day 5. So what did we see from the live births from day 6 culture? So only day 6 culture. We were not doing anything on day 5. We were only freezing embryos on day 6. So to cut a long story short, if you compare our control groups with study groups, you can see that in the study groups we were doing mostly day 6 and day 7, so we could compare those two groups. And then in Clinic A, as I said, you could see our live birth rates were about 62% from our standard invasive PGT. But then when we looked at our control groups from invasive PGT on day 6 and day 7, we were about at 61%. And from the study group, we were about 65%. So all in all, the impact of actually extending or changing your Coulter protocol and only freezing on day 6 appeared to have no impact on our live birth rates. And you can see in the other clinics who were doing a mix of day 5 and day 6, when we separated the data and we looked at day 6, we also found no actual difference in the live birth rates in their day 6. So the first question, are we harming the embryos by actually changing the protocol to day 6? It appears, at least in our hands, that we were not doing any harm for that, doing that change in protocol. The other question is this 80% concordance rate. So are we actually looking at the embryos at the right time? So what we started doing, and this was done by one of our clinical embryologists, Goliath Dastani, who we actually looked at changing the protocol and seeing if we actually cultured embryos not from day 4 to day 6, but because we had the knowledge that it was only day 5 blastocysts actually secreting this DNA or budding off this DNA, what happens if we only concentrated on day 5 embryos or day 6 embryos? So we did a change in protocol. We thawed discarded blastocysts. We cultured them at day 5 for 8 hours, day 5 for 25 hours, so overnight, 24. Or we did a short protocol where we had day 6 embryos and we cultured them for 8 hours. And then we looked to see, we did the media, we already had the whole blastocyst data and the PGT data. So we wanted to see, were we able to actually extract more information from changing this culture protocol? So, in terms of information, so when we were able to get enough DNA to give us a meaningful result, you can see the day 5 short protocol, and I won't go into all the different grades, but in effect the grades are very similar. Probably around 50% of the time we were doing a day 5 culture, take a day 5 embryo for a short protocol, we were able to get information. But doing a long protocol for 24 hours, we were nearly at well over 95%, and looking at a day 6 short protocol, so taking embryos at day 6, culturing them for 8 hours, again, we were nearly able to get nearly in all the situations, around 90% of the time, we were able to get information from that culture media drop. More importantly, when we got DNA in the media, day 5, obviously, we were only getting it just over half the time, but on day 5 long and day 6, our concordance rates were well in the 90%. So the question of a lower concordance rate in the 80s, we were able to actually get, in some cases, nearly 100%, changing that culture protocol. So it sort of backed up our data that when we did the live imaging, we only saw blastocysts putting out this DNA. And in the culture protocols, that sort of is mimicking our answer from the live cell imaging that we had. So basically the concordance rates, if you change your protocol, you can actually get to these levels of much higher concordance rates. And you can see here the informativity for the short protocol was around 50%, but then when we looked at concordance rates, in only looking at blastocysts in culture, we were well into the 90% range. So you can see here, this is summarised, you can see how many embryos. We did about 20 blastocysts in each group. I know it's not thousands, but blastocysts are not easy to get to. But you can see our concordance rates again were in the very high 90s or the 100% range. So it appeared that when we looked at the blastocyst as our tool for actually getting DNA, that it was much more informative and more sensitive in terms of getting concordance rates. So the questions we had in terms of protocol for non-invasive PGT, I think it would save you time as an embryologist. Do you need trained embryologists to perform the biopsy? You're not doing a biopsy, you're collecting media. These are things that embryologists are well trained to do, hopefully. So does it remove any theoretical harm of the biopsy technique? We really don't know that answer yet, I think. Is it a new technique? People are scared of new techniques. So, you know, this we can't change. It depends on the type of mentality of the different laboratories. are the concordance rates acceptable? I think you're getting to a level, if you are able to adapt your protocol and you're willing to do that, that you can actually get to very good concordance rates. Does the change in culture protocol, so does it taking to day 6 and only doing freezing on day 6 cause any harm? It appears, at least in our hands again, that it wasn't causing any harm. So how would you do this eventually? So this is the theoretical hope of using a non-invasive technique, and you could say a patient had 1, 2, 3 or 4 embryos. At least you're getting some information on them, and you can actually rank them in order and transfer them in a particular order. So if a patient had 2, you would put this one back first and this one back second. If they had 3, you would rank the highest one again. If a patient was lucky enough to have 4 blastocysts, you may transfer these 3. You may choose to discard that one, depending on the protocols you have in your own lab. So thank you. If you have any questions, you can email me on these numbers, and I'm happy to answer any other questions you might have.
Thank you so much, Danny. It was fantastic. You just gave us a very insightful presentation. And it's great to hear and to see on data and results that non-invasive PGT-A is safe. So if we already have this information that it's safe, not causing harms to the embryo, so what you would guess that can be the challenge or technical other challenge for adoption of Embrace?
Well, it's like any new technique in laboratories. I think there always there are hurdles to actually adopt these technologies. So obviously, invasive PGT, especially in the US, is a very ingrained technique now. There are many clinics doing 100% invasive PGT, and it works effectively for them, and they're used to doing that. So there's a comfort zone in actually doing these techniques. So, obviously changing to day 6, freeze all. There are pros and cons. You have the concern, of doing the day 6. The bonus is you're not actually freezing your embryos on day 5, so you're actually limiting the amount of work. The embryology labs become very complicated. If you're freezing a patient day 5, day 6, and then day 7, you've got 3 different touch points for the blastocyst. You might have just cut that down to 2 if you're doing day 6, day 7. It means you're tracking embryos over 3 days rather than 2 days. So there are other bonuses that you would have, and obviously the fear of concordance rates and is it equivalent to what we expect from invasive PGT? And I think those answers are slowly coming out. I know there's quite a few European clinics or non-US clinics that are adopting this technique now because in non-invasive PGT might be more amenable to the laws of a country or the way they practice. And we all know in Europe that invasive PGT is less popular, let's say, in especially the northern countries. So I think slowly, it's going to be a technique that will take time, but there are some benefits to these types of technologies, I think.
And perhaps personalize the necessity from the patient and just use the proper technology for the proper cases, right?
It could be, maybe, I know groups have spoken about, possibly doing non-invasive PGT for younger patients and maybe keeping the invasive PGT for older patients until they're more comfortable. So, that comes down to the economics of the technology too, but that could be a strategy, I think, for people to get more comfortable. There's quite a bit of data out there indicating differences in outcomes with different PGT strategies, but that's maybe a type of strategy you could adopt initially to get more comfortable with the technique.
Dr. Sakkas, I want to thank you for your time, for your wonderful presentation, and I want to be mindful for our colleagues that are watching online. So please take a note of his email or stay around and you ask your further questions to Danny here today. Thank you so much.
Thank you.